My name is Ernie Yap, and I'm a nephrologist at SUNY Downstate. In the next 10 minutes, I'm going to describe some of my personal experiences with Renasight and as it pertains to APOL1 discovery. So my encounter is this, case one, a 31-year-old African-American male whom I met and inherited from my colleagues at the dialysis unit. And he was seen during my rounds on dialysis. And the point of review of his chart, he was diagnosed with renal disease 2 years prior when he was 29 years old. His past medical history include hypertension and nephrosclerosis, which was confirmed by biopsy. It was done before his introduction to hemodialysis, and that showed collapsing focal segmental glomerulosclerosis with arteriosclerosis and hyalinosis and 80% fibrosis. It wasn't long before he did not respond to corticosteroid therapy and was started on renal replacement therapy. And upon further questioning, there was no family history of renal disease. So out of curiosity and after discussing with him at length, we decided to pursue Renasight test. And it showed something that was not unexpected. He did indeed have homozygous inheritance of the high-risk APOL1 variants. In his case, it was the G1. And note, and we're going to discuss this, the implication of this further, this COL4A4 mutation, and which was implicated in this report as in Alport syndrome. So that kind of brought me back to his bedside or chairside and interrogated him much more deeply in his family, and there was no Alport phenotype at all. So what transpired after that, at around the same time that I got the Renasight result, he left my dialysis unit after receiving a kidney transplant from a relative. And that raised more questions than the answers I got from him, that what was the implication of the transplant with APOL1 inheritance within his family. As we know from smaller cohort studies, the high-risk APOL1 mutations in kidney donors are linked to shorter graft survival and lower post-donation eGFR. However, before we could discuss this in detail with him, he has left my practice and moved on to his post-transplant care. Patient that I encountered during the dark days of the pandemic in New York City is a 25-year-old, very young African-American woman who first came to the emergency room with respiratory symptoms in March, and we all know what happened in New York City during that time. So, and not unsurprisingly, she tested positive for SARS-CoV-2. At the time, the recorded creatinine was 1.4, and she was sent home after receiving some supportive care. But around a month later, she came back to the hospital with severe kidney failure, and I was on the consult service and we were called upon to see her. Her creatinine was one of the highest ever at 28, and she was pouring out about 10 grams of protein per day. So she was started on hemodialysis, and it was more so in preparation for kidney biopsy. And that showed collapsing glomerulopathy with acute tubular necrosis. And interestingly, on electron microscopy, there was direct invasion of the glomerular cells by particles resembling the coronavirus. And she was one of the first, she was the first among many that was soon reported in other places, cohorts and people who had this propensity of getting a COVID-19 associated AKI. So kidney function improved with time after I started her on oral prednisone. And 5 months later, upon follow-up, her creatinine improved to 2.6 from the height of 28, but she still had persistent proteinuria around 3 grams. When she saw me in the clinic, and we decided to pursue the Renasight test, and again, non-surprisingly, the only positive variant came back was homozygosity for the G1 high-risk variant. So what were the next therapeutic steps for her? She is currently still in the current state of proteinuria and CKD, and cyclosporine and tacrolimus were being discussed, and potentially rituximab. But is the overall renal prognosis for COVID-associated FSGS with underlying APOL1 remains an unanswered question. So in summary, there are some common denominators of these cases that we encountered and clarified with Renasight. Patients were of African-American ancestry. All of them were relatively young and had very severe kidney disease, which prompted the decision to do a genetic test. And there was no suggestive family history, although that may not be true for every other patient with APOL1 homozygosity. And all of them also, if one digs deep enough in the history, has encounters with second hit mechanisms. Now, in the APOL1 literature, we know that APOL1 homozygosity, not everybody will end up with CKD, and those who do have clearly delineated acquired second hits such as HIV, parvovirus B19, cytomegalovirus, BK. SARS now has been increasingly, SARS-CoV has been increasingly implicated, and there are some non-infectious inflammatory states like SLE preeclampsia. How about inherited gene variants? The COL4A4 or other collagen genes, for example, and this complement 5 deficiency. So those were all questions that I had that came running through when we do a broad-based genetic interrogation like Renasight, and we kind of formulated why did I do it and what advantages it has afforded in terms of clinical care. It has revealed heretofore unknown insights into the patient's CKD stage. Knowing what caused their current clinical condition, such as ending up on dialysis machine, empowers patient, and knowing them just enables them to take much more ownership into the self-care. That it was an inheritable condition, and this knowledge about APOL1 has enabled a lot of people to understand better as to this early onset hypertension that were thrust upon them at a very young age. Knowing also has implication on the treatment plan and prognostication on part of clinicians. So if I just wish I had caught the APOL1 homozygosity in the first cases earlier in their life prior to hemodialysis, and probably if their clinical course was taking a different trajectory. And doing Renasight, because it doesn't test for a single mutation, it challenges a paradigm of long-held beliefs regarding certain conditions. For example, early onset hypertension, things that and nephrosclerosis, things that we have usually attributed to uncontrolled external factors, were in fact intrinsic, inheritable factors. But there's much more to learn. And if I were to do things over again, perhaps in the future, I would offer Renasight to people with at earlier stages of disease to leverage more treatment options and potentially involvement in the clinical trials. And I believe there are efforts in doing that right now. And more knowledge in terms of folding counseling to patients, especially pre and post testing, knowing what we're looking for, instead of a blind or a wide array of genetic mutations, very little meaning to the individual patient. And also when the results are back, that we have more knowledge into the post-testing counseling. Definitely more research is needed on the phenotypic impact, especially in terms of APOL1, where the genetic inheritance is well delineated, but not so much how it impacts the phenotype, especially post-transplant, for example, in the first case. And certainly much more in-depth insights into the other non-APOL1 variants is needed if I were to offer Renasight to many more of my patients, and they may come back with, for example, C5 deficiency and CKD, and the literature is not rich in terms of providing a causation or causative explanation. So that is a much unexplored area. That's the end of my slideshow. Thank you very much.